Hello, everyone, and welcome to the Babies in Common Show. I am Jeanette.
And I'm Melissa. Welcome, listeners. As a reminder, any information shared during this show is not to be taken as medical advice. Please consult your own care providers for questions about you or your baby's health, or visit babiesincommon.com/disclaimer to read more.
So it is Thanksgiving week 2020 here in the U.S., and although this year has been such a difficult year, to put it lightly, for so many and on so many levels, I think a great way to start off the show today would be to say one thing that we're thankful for. So you go first, Melissa.
All right, I will. I'm going to be cheesy, Jeanette, and say that I am thankful for you
Aww.
and this opportunity to start this podcast with you. I mean, what started off as a quarantine project back in April to try to get information about birthing during COVID to, expecting parents in our area has really grown into this amazing weekly podcast that's listened to by expectant parents all over the country and all over the world. And I can't believe we are currently taping our 40th episode.
Yay! 40.
I think that's so great. So I am thankful to all of our listeners and this opportunity to help get research-based information, resources, and support to all those that need it. So what about you, Jeanette?
Well, of course, I'm also super thankful for you, Melissa, and the fact that you wanted to do this with me and have kept that commitment means so much. And I'm also thankful that this pandemic happened in a time when we have such great technology that we can not only do video calls with friends, family, and colleagues, but we can also help families through the internet and virtually with video when in person isn't the most optimal at the time. And so, gosh, I was thinking, like, what was it like when there was a pandemic 100 years ago? I guess people just read a lot of books.
We are lucky in that way for sure.
And I know this pandemic has produced many children, so I'm curious to see those numbers when that comes out. What to compare it with the 18 or the 19, what was it, 1918? I'm also thankful that my dear friend Renee Beebe is back with us again to talk more about how words matter, but this time in the context of pregnancy and birth. So for those newly tuning in, our guest today, Renee Beebe, is an international board certified lactation consultant in private practice in the awesome place of Seattle, Washington. She's been a lactation consultant for more than 20 years, doing home visits and working in a naturopathic physician's office where she sees families and assists with frenotomies. She's the proud mother of 2 grown women. In her spare time, she loves to garden, play violin, and hike in the nearby mountains. And you can learn more about Renee at second9months.com, and the 9 is the numeral 9. So thanks for joining us again, Renee, to go back to Words Matter about birth.
Thank you. I haven't been playing my violin much because we don't have an orchestra this year because of the pandemic.
Have you guys done a virtual one where everybody gets on Zoom and plays music?
You can't do it with Zoom because you can't have more than one channel going at the same time with Zoom. So, we can't all 3 of us talk at the same time, right? So if you have 5 people playing instruments, you can't hear them all. So there are some apps, but they're not ideal. Oh, no, they're free, but you've got your headphone on, you've got your instrument, and you're trying to listen to everybody. It's not exactly what I signed up for.
Wow, I didn't know that, because I've seen people like our friend Dana Renee. She's a singer, and I feel like she posted something where everybody was singing, but I guess they must have all pre-recorded it.
Yep, they record it all separately, and then somebody has to come and mix it all.
Yeah.
Oh, wow.
Yep.
See, now you know the magic behind the scenes.
Learning something new every day. Shout out to Dana. Look at that.
Speaking about magic behind the scenes, if you haven't yet listened to episode 38, listeners, be sure to check it out as we discussed how words matter in the context of infant feeding and parenting during that episode. And it's so great to have you again, Renee. And I love that, again, we're talking about words because words impact us in life in so many ways, and so many more ways than we realize. And that is especially true when you're a new parent, as your brain is so very sensitive to imprinting at this time, both positively and negatively, wouldn't you say?
Oh, absolutely. I was kind of crazy at that time. I think many of us are. And yeah, I think last time we were talking about nursing the baby for a particular number of minutes on each side. And I know I remember very clearly with my first one, panicking because she was starting to slow down on the breast after 7 minutes, and they told me 15.
Right.
It's like, oh no, keep going.
and then what do? We're told back in people are still told to do it, like blow on your baby, flick on your baby, tickle them.
Yeah.
It's like
all these mean things.
Yeah. be nice just to squeeze your breast and get more milk in there.
Well, I know that you are both fantastic, fabulous IBCLCs, but my wheelhouse is what
It's
we're going to
for
be
you
talking about
today.
tonight. Yes, pregnancy and birth. And as an OB nurse, I can think of plenty of examples of how negative the obstetrical lexicon is. When you really start to critically think about obstetrical medical terminology, so many healthcare providers are taught to use reflexively. You begin to realize there are just so many negative words that set our brains up for accepting intervention or feeling like our bodies are failing us. And so let's start with one that I know everybody has heard of, going late. What do you guys think of that one? Quote unquote, going late, the old going past your due date.
And actually, Renee, since you've been practicing for a little longer than I have, was going late a big deal when you first started practicing in the world of babies and pregnancy and that kind of thing? Was that like talked about as much?
I don't hear the term going late here. I hear the term, post-term or past the due date, or those kinds of things.
Overdue.
Yeah.
But still, the concept of it being a negative thing.
Not as much. Like, I didn't see quite as much inducing, I think, because I really wanted to have this provider and they weren't going to be there, so we induced, or I don't think I saw that as much. It was certainly still a thing. Definitely,
sure.
Yeah, but even when my mom was giving birth, it was a thing.
Synthetic prostaglandins like Cervidil, for example, which is that little suppository that they put in your vagina that secretes the synthetic prostaglandin, helping to get your cervix ready or ripe for labor. Those weren't invented until, the 90s. And so, don't quote me on that. I'd have to look it up, but it certainly wasn't something that was back in the day, right?
Even the word you just used, ripe. Right? You're going to ripen.
Right.
Because we're fertile and ripe.
Right. So, once that was a big problem in the 90s when, we started to see this spike in what's called iatrogenic prematurity, which basically just means that the hospital staff has caused a baby to be born before they're ready. And the March of Dimes led the campaign against elective inductions before 39 weeks, because even though babies were, quote, full term at 37 and 38 weeks, they weren't ready to be born. And so these synthetic prostaglandins were making it easier to induce people that weren't really ready for labor. And, it was a big problem. Luckily, there are some places that have stopped elective inductions, meaning an induction without medical intervention. But there are so many places that haven't. And this concept of going late, quote unquote, research shows that it's normal for first-time moms, especially, to go 7 to 12 days past their, quote, due date. It really should be called a guess month, not a due date. That's another term, right? Due date makes it sound like it's a deadline. It's not a deadline. It's a guess month.
But I even hear people saying, well, my baby came early. And I'm like, oh, when? Oh, well, they were born at 39 weeks. I was like,
right.
That's not early. Even 38 is not
exactly.
Early. You just weren't ready because you got it in your head that it was due date. And so the baby was born before they were due. So that's early. No, it's a time frame of several weeks where it's normal for them to come at that time. And,
I didn't know
this
that
idea
about
of going late.
I didn't know that.
The March of Dimes.
That's really interesting.
Yeah, it wasn't from the obstetrical community that was trying to put a halt on elective inductions. That worked very well for their time and their pockets, let me tell you. So,
well, I also think the issue of being overdue, as you kind of alluded to it, but to clarify, it's that sometimes we're trying to get the parent's body ready to give birth, but maybe the baby's not ready.
Right.
Oh, right. Yeah, there's two parts to this equation.
So even if your body goes into labor and you end up going into labor and having the baby, what if the baby's not ready? But also, oh my gosh, now we see so many people who are induced just because of a certain date, and then they don't go into labor with all the interventions, and then they have a cesarean because someone decided that they should have had the baby already, when really, was that really necessary? And I know sometimes it was, right? But at the levels
Sometimes
it's
it
at
is,
right now,
and
you know, it's a lot.
I am very, very grateful to have medical interventions and all the agents that we
Mhm.
use to induce, because if it is not safe to remain pregnant for mother or baby,
Right.
then induction helps us avoid major abdominal surgery in any case that it works, right? If
Right.
it's not safe to remain pregnant, then we have to end the, we have to get the baby out. Then,
Mhm.
induction agents like Pitocin and whatnot are incredibly awesome, effective obstetrical tools. But with everything there comes risk. And so if we're doing this electively, or for what is called on the down low, we call it a soft call, right? Someone's being induced for post dates, quote unquote, using scare
Right.
quotes here, but they're 1 day past their quote due date.
Mm.
That's not post date. It's a guest month. So,
Yeah.
people who are following evidence-based practice would not consider offering an induction for going late, right? Quote unquote, until you're at least 41, but closer to 42 weeks. And at that point, it still can be a discussion. I like to joke in class that everybody has a uterus oven, and everybody's uterus oven cooks at a different temperature. And, your uterus oven might be very efficient convection uterus oven, and her uterus oven might be a slower, older model uterus oven. And it doesn't matter. But you're gonna, if I put my cookies in that fast oven and I got a slow oven, I'm gonna burn my cookies, right? And vice versa. If they take their cookies and put them in my oven, they're gonna be underdone. They're gonna be soft. So everybody's body cooks their babies at a different rate, and so you don't know.
I think we could go too far with that analogy.
Yeah. we don't want to overdo them.
We don't want to cook them too much.
Well, I think also from the perspective of Jeanette and me as lactation consultants is that if we're not considering the baby, obviously, like you said, health reasons are paramount. But the baby's not ready. If the baby's not ready, then not only do you have the problems, like you said, the snowballing kind of problems which may lead to a C-section, but you may have a baby that just isn't quite done, if you will, and not quite ready for the world, not quite ready to breastfeed as well as they could. So you have a lot of
and in our last episode, we talked about suck, swallow, breathe. Yeah, and how that has to develop. There's an incredible amount of brain and lung development that happens in the last 2 weeks of your baby's natural term. Meaning, if we had a crystal ball and we could figure out when your baby was ready to be born, the 2 weeks prior to that has an incredible amount of brain and lung development, and also development of suck, swallow, breathe, ability to regulate temperature, ability to regulate blood sugars, et cetera, et cetera. So even if a baby is, quote, term, if they weren't close to their crystal ball birthday, right, then we could be delivering a baby that's not quite ready. And that's actually why more than 20 years ago, and it's still not a phrase that's used very often, but more than 20 years ago, we changed the terminology that it is no longer considered full term at 37 weeks. 37 and 38 weeks are considered early term, and you're not considered full term until at least 39 weeks. So that's something that a lot of people don't even know. That was a term changed a long time ago.
Interesting.
All right. So next up, this is one of my, if we're going to talk about pet peeves, this is one of my personal pet peeves: rupture of membranes, which just sounds so horrific, right? Like when I think of a rupture, I'm thinking like an eruption, like a volcano, like breaking the water is, seen as a lesser term, but it's still something's broken, right? Yes. What do you guys think about that term?
Yeah, it sounds so violent.
I think I like to use the same word that we talked about related to tongue ties, is that it's released.
There you go. Yeah, or like actually Renee said about the letdown. It's not the letdown, it's the release of the milk.
It's the let out.
Yeah, same idea. I mean, really, the let out. Yeah. I mean, because what they're doing anatomically, physiologically, is they're basically snagging a little hole in the bag of waters, which is essentially looks and feels like a latex water balloon. So they're just kind of poking a little hole in it, and that water around the baby's head is released out. It's certainly not as dramatic as a rupture of anything.
Right. Yeah. Breaking. Oh, and then ripening. We talked about that one, right?
Yes.
We're not pieces of fruit.
Yep.
The other thing you would mention, the prostaglandin, and Melissa. So there's also a type of prostaglandin that is called misoprostol, is the name of the medication, and
Mm-hmm.
people shorten the name in the medical community. They call it meso. And I have had multiple people who've said, I don't know, they put up this like soy stuff or like that stuff like miso soup, like, and I'm like, whoa.
Oh my gosh.
Like they just like, no,
I
that
have
was a
never
medicine.
ever heard that.
Yeah, like because they're trying to remember what it
Wow.
was, and I don't know that they even realize. Like, are they really thinking they put miso soup up there? Probably not. But they're just like remembering what
That's
was
what
that
they
thing called?
remember.
But what I
No,
think,
no.
and I wonder,
But you know
is
what's funny?
I wonder if people
No, you say.
in the medical community feel like that was that ever done on purpose. I mean, like, well, if we say miso, then they'll think it's a lesser, because it's a pretty controversial. We use that word controversial again, but it's got a storied past, this drug, and so it sounds like no big deal if it's just miso.
No, it's
Right?
funny. I've read a lot of books about the history of birth, and I haven't come across that being an intentional
Sure,
like,
I know.
cover up.
Right. Yeah.
But I know that we do that all the time in medicine. We shorten things all the time.
Sure.
And it definitely makes it even more complicated for patients to understand what we're saying when we're not only talking in medical jargon, but we're also shortening that medical jargon. So I think that as healthcare providers, we have to be mindful that we say we're going to be using a drug called misoprostol or Cytotec, and it is a tiny pill that we insert into your vagina. Because what's funny is, you know, you're saying miso soup, is it a soy paste, a fermented bean, you know, and people might be laughing like, who would think that? Well, the funny thing is there's actually something called laminaria, which are dried seaweed sticks that you can insert into someone's cervix to also induce labor. And that's usually done in the context of termination of pregnancies for congenital anomalies. But yeah, they literally look like short pencils. Like golf pencils that are just, they're dried, like hardly wound seaweed that when you insert it into the hole of the cervix and you basically put a piece of soaked gauze up against it, they will slowly expand and swell to open the cervix. So it's not that far off if someone's thinking we're throwing miso paste up there.
Yeah.
Because we do a lot of crazy things in medicine.
Like what you were saying though, Jeanette, I think when people use acronyms and abbreviations and stuff like that, they are talking above the patient. They are using shorthand to communicate with each other. And you know, I have a big problem in our professional groups when people use abbreviations and acronyms all the time, just assuming that everybody knows their lingo. And I think most people don't speak up because maybe they're embarrassed. Maybe they think that they're supposed to know what that is. And so I imagine that happens a lot in a hospital setting where nobody says, excuse me, what is going on here? Because everybody's just saying, oh, we're just going to do a little miso. And, you know, and so I think it really is another way that, you know, the patient is devalued.
But even that word patient.
Yes.
Right. Okay. I had a long conversation with a very close friend of mine who's a longtime midwife, certified nurse midwife. And I was like, I don't like the word patient. I don't even like that word. I would like to say like client. Because you're serving me. And she's like, I still kind of like patient.
This one's hard for me, and I'm gonna have to put on my nurse cap, my white nurse cap for a second, because I totally see why people don't like the word patient, because it implies that there is some type of illness and we are caregiving. Like if my grandfather's in the hospital as a patient from open heart surgery, there's something sick, and we're trying very hard in the world of obstetrics, right? We're trying very hard in the world of maternity care to convince pregnant women that they are not sick, that labor and birth are an inherently normal biological process, right? That being said, the profession of nursing is one that has been devalued as a profession for a very long time. And when you go into the history of nursing and how we came about, and we were employees of the hospital and we worked for nothing, and doctors treated us like garbage and still do in many places. You know, I have to remind physicians in 2020 that I do not work for them, that I answer to senior nurses. Right. So this is a problem in 2020. So as a profession, collectively, nurses, in nursing school, we learn so much about the nurse-patient relationship and how important that is. And patient in nursing school is something that is valued. Learning how to be compassionate towards patients, helping to promote wellness and health and education with patients. And it's not a client because we're not in a business relationship. We do not bill for our services. That's actually another problem with nursing, right? Is that all the work that nurses do, you can look at an itemized bill in a hospital and see even down to the, Tums that they've given you, they're going to put a monetary value next to, but that nursing care is nowhere on that bill. So I think we have to come up with a different term, because in maternity care, there's so much about, the medical model of nursing and medical care that doesn't pertain, right? Like, for example, the pain scale. We've had to fight for years to convince places like the Joint Commission, like organizations like the Joint Commission that say everybody needs to document a pain scale every so often. We have to like lobby for years to be like, I'm not asking my laboring patient every hour what their pain scale is on. Their number is on a pain scale. That is clinically irrelevant. It doesn't make sense, right? So like we in maternity are fighting against this like blanket, because it's not the same thing as the person who just had open heart surgery, but the nurse patient relationship is something that is so very special in nursing that I see how that nurse midwife was like, no, but it's not a client. She's a patient because we care about patients. Right?
She didn't explain it that way. We
gotta find a middle ground.
Yeah, she didn't explain it that way, but I think
we got to find a middle ground.
Even the word patient almost means like, okay, you're laying there and trying to be patient while someone takes care of you. Like, no,
patient, I hear you. Like I can see both sides. I totally see both sides. Like, because we are both nurses care very deeply about the nurse-patient relationship, and we have a different scope of practice than any other profession as far as how we interact with patients. But also, laboring people are not sick, and they're not in a hospital gown. They shouldn't be in a hospital gown in bed, and and asked about their pain scale every hour.
I'm curious, Renee, because you work in a naturopathic physician's office. Is it there that you say patient instead of client?
Yes. Yeah. We say patient.
Yeah.
I try to, even it's hard for me because I don't see my clients there as patients, but they are patients when they come in there because that's how they are within the physician's practice. They are patients.
Right.
So yeah, it is a funny thing because I've had clients for so many years, and then all of a sudden I'm referring to these people as patients just because they're coming to see me in a physician's clinic.
Right.
All right. So this is what we have to do now. We have to put our heads together and we have to come up with a different term. Not lawyer-client relationship, not doctor-patient relationship. It's got to be something special to maternity care.
It really does. But, there's a lot of times that within, a doctor's office too, that they are seeing well people all the time, like especially in a naturopathic physician's office, they're seeing well people and helping them get more well. They're not necessarily sick. So yeah, I don't know.
Well, I would still argue that we shouldn't be calling, we call a doctor and a midwife by their first name, and not a doctor, a midwife and a nurse by their first name. But doctors, I still think, like, come on, it's 2020. Can we just call you by your first name?
Yeah.
Like, especially if they're like younger than you, like, really?
In my area, I think there's a lot of first name doctors. Yeah, I think it's a lot more casual over here in the West Coast.
Oh, yeah, maybe. Yeah.
Yeah.
So another word.
Oh, I got a question. Actually. Yes. Sorry, before we have another word. Okay, so here's my big beef with the West Coast, if we're going to have a little, calling it completely dilated instead of fully dilated. This is my big beef. I hear from West Coast nurses all the time. She was complete. I'm like, she wasn't complete. She got to complete. 10 centimeters. She got a long word to go. She's got a long way to go.
We are complete.
What do you think?
You complete me.
I never knew that was
Jeanette?
A West Coast thing.
Is that a West Coast thing?
Oh, that's a West Coast thing. Yep. They say complete instead of fully. So what's funny is we had this one doctor attending when I was first a labor and delivery nurse that, we had the board. Everybody knows the board, which was the patient board. Everybody's name was on and their dilation and who their doctor was and blah, 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 right? And he would always put C next to in the dilation column for anybody that was 10 centimeters,
Oh.
which C means closed. So
Oh,
this
no.
caused a huge, because closed is very different than 10 centimeters.
Yeah, very different than complete.
Exactly. So we were like basing these like assignments off of like, okay, you can take patient 1 and 2 because, you know, they're both closed. They were like both fully dilated. So we had to have a little talk about that. They're not complete. They're fully.
No.
If anybody in the West Coast is listening, I'd love for you to email me a rebuttal to that at info@babiesincommon.com and tell me why I should change, because I just think it should be fully. Okay, Jeanette, you go next.
Yes. Okay. So failure to progress.
Oof, yes.
Failure. But they use that in lactation too, like lactation failure.
Yes. Failure.
Not even just the parent themselves saying, I feel like a failure. Like there's actually like a
Also,
professional
failure
term.
To thrive.
Right.
That
Failure to
one
thrive
too,
for the baby.
failure
Like
to
really,
thrive.
the baby is failing to do something.
To live.
Yeah.
Like
yeah.
the one thing that we're supposed to do.
To not do that. Yeah.
Like
oh my
like
gosh.
a 30-year-old
Yeah.
failing to launch.
Yes.
That's very different than a baby who's
might
not
be.
gaining weight.
That failure
Not the same.
to progress. I hate that.
Mm.
And Jeanette, can you talk a little bit about one of Massachusetts' only spinning babies parent instructors? You are. Can you talk a little bit about how failure to progress, or what other people call like stall in dilation, actually isn't a failure or a stall at all? Or, you know, what could possibly be going on there?
It's likely that the baby's not in an optimal position to help the cervix open. And sometimes the cervix may open, but the baby's not in an optimal position to come down and go through the pelvic muscles in order to spin, so to speak, or turn in a way that optimizes their head coming out in an easy way. And so it's really a challenge when it's failure to progress. It almost just is looking at the muscle of the cervix only. And oftentimes that can happen, I don't know what the statistics are when they're looking at this, and there's not that many studies yet on spinning babies techniques, but that, you know, a lot of people in our culture are laying down for so much of labor that they're not even using being upright to help open that cervix, of using just gravity. And so the failure to progress really makes it sound like there was either a problem with the person or the problem with the person's body, when so much of it is the position they were in or the position the baby was in.
Yeah,
absolutely. Or there's a restriction.
It's making it all about the mom.
Yeah.
You know, you didn't progress. Instead of this, again, it's like breastfeeding. It's another interaction, right, between the baby being in the right place and the mom's body.
Yep.
Yeah, think about it. If a baby has a restriction in their mouth and isn't effectively latching, and then the mother's like, oh my gosh, I failed at breastfeeding. You didn't fail. There's two parts to this equation, same as labor. If the cervix is held up from dilating because there's a restriction in a ligament that's attaching the cervix to the tailbone, or the baby's having trouble descending into the pelvis to put appropriate mechanical pressure on the cervix, and maybe, not always, but many times, if you are using different upright pelvic opening or dynamic position changes, right? Gravity favoring position changes, we can help correct those things and give the baby the space they need to make their way down. It's not a failure. We need to troubleshoot this. Like you guys were saying in the last episode, you know, just accepting something as is instead of investigating. Like Jeanette was saying in episode 38, like if your kid was limping, the doctor wouldn't just be like, well, he can get around. He'd be like, why is he limping? Let's try to fix this. Right. If the laboring person has, quote, you know, stalled in dilation, is failing to progress, instead of just saying, well, mom's body's broken, she needs a C-section. And then the worst thing, my biggest pet peeve of all, is then telling that person, oh, see, yeah, you know, this is a 7-pound baby and you couldn't even get them out. So you're just going to have to schedule a C-section next time. Right. Like, think about what that makes you feel like when you get your hospital report, or you're told by that provider at your birth, yeah, your C-section was for failure to progress. You think you're really going to try to attempt this all over again? Like,
because your baby was too big.
Right. Too big for you at 7 pounds, honey. I've seen so many C-sections for 7-pound babies, 8-pound babies, that then that person goes on to have a vaginal birth after cesarean for a 9, 10, 11-pound baby. I've seen dozens. It's like Renee, you were saying, it's two parts. There takes two to tango, babe and parent, right?
I'm
All
sure
right.
you
So
see a lot of that.
here's another
Totally.
thing that is, really gets me going. This is the episode where my blood pressure rises, Renee.
Okay.
Advanced
Bring it on.
maternal age.
Oh yeah.
Or the
Ooh.
more clinical term, and this is not a joke. I got some looks at a grand rounds once when I was a very new nurse. One of the residents said, an elderly prima gravida. And I burst out laughing because I thought he was joking. And I got like all these looks from maternal fetal medicine, like stared me down. I was like, that's actually the term.
That's
Yeah.
a
An
word.
elderly pregnancy for a pregnancy over 35 years
Yeah.
of age.
Elderly.
That's crazy.
Yeah. Well, I was in that category.
Hmm.
Yeah.
So did you need a walker to get to labor? Or
Yeah.
like,
Totally. Yeah.
AARP card to show at the
Advanced
door?
maternal age. And yeah, I learned a lot in that time. This was with my second baby, and I thought it was just so interesting because she was born when I was 35, but when I was, most of my pregnancy, I was 34. But because she was going to be born when I was 35, then I had to turn down all kinds of tests.
Oh yeah.
So I said, okay, so wait, so I asked the question, so if she was going to be born a month earlier, you would not be recommending an amniocentesis.
Good for you for asking that.
And they're like, yeah, exactly. And yeah, it just blew my mind. Like, okay, I get it that, my background's in special ed, right? I know about genetics. I know about, that there's more chromosomal issues after a certain age, but it was interesting that it's not like I was 42 or even 36, but I was going to be 35 a month before my baby was born. So therefore, it put me in this other category of all these potential problems that everybody was talking about all the time.
But there are young people that have those problems. I have a client who
Of course.
just gave birth all natural, no interventions whatsoever at the age of 52, I think it was.
Whoa.
51 or 52. Yeah.
That is impressive, hands down.
Yeah. Absolutely,
that is
rock
truly
star, right?
advanced maternal age. Yeah.
But you can't just always assume.
No, you can't. Not everybody's fits the same mold. I mean, we actually talked a lot about this with Jen Shark, who's the midwife that we interviewed in episode 13 about pregnancy and parenting after 40. She was so eloquent in talking about how, yes, there are some increased risks to pregnancy that, can occur at higher ages. However, you are an individual. And so while the world of medicine and healthcare, is going to compile these statistics about risks of diabetes and high blood pressure and all these things that might make you at increased risk to develop, if you, as this 38, 40, 42, 51-year-old person actually is not developing those things and is growing a healthy baby and is having a healthy pregnancy, then you are an individual and should be able to have an individualized discussion about risk-benefit alternatives to medical interventions. Should not be placed in a box.
Exactly.
But Renee, don't you hear that? Sometimes people are told that they're advanced maternal age and then they automatically assume they're going to have problems with making milk because they're older.
Yes. And, this actually, this age thing, this is something that I don't remember happening, 10, 15 years ago, where automatically, if you are older than I think 39, then we absolutely are going to get the baby out by 38 weeks, period. No, end of discussion, because of some, exponential risks, possibilities. I don't remember that happening 10 years ago. And now it seems like, I have so many people in my practice who are over 40 and they all are like, yep, you're having the baby at 38 weeks, which of course leads to more C-sections and more babies who are having difficulty with breastfeeding, etc.
I would encourage anybody who has been told that they have a pregnancy of, quote, advanced maternal age to check out evidencebasedbirth.com's really well done signature article on that, because Rebecca Decker really outlines all of the research surrounding that. And, please know that many of the recommendations for medical intervention for advanced maternal age, including induction just for age in and of itself, do not kick in until age 40. And this idea of advanced maternal age being 35 is what Renee was talking about. Mostly that's considered advanced maternal age, not necessarily for complications with pregnancy or delivery, but for an increased risk of potentially having a baby with a chromosomal abnormality like Down syndrome. And so, everybody has different thoughts on that as being a risk. But if you, let's say, don't have a baby with Down syndrome and are 35 years old, then don't consider yourself advanced maternal age, I guess. Like, if that's, you know what I mean? Like, there might be, there are certainly issues with pregnancies with babies that have chromosomal abnormalities and whatnot. And those pregnancies might need additional care, and those babies might need additional care at birth. But, it's like, hey, you might have an increased risk of gestational diabetes. You're high risk, and then you don't develop gestational diabetes, and it's like, but now you're not high risk because you didn't get
that label gets in your head that you're high risk.
It totally does.
I've seen people who are high risk to miscarry,
right?
And they still at 39 weeks are like, well, I'm high risk, and I'm like, not anymore.
Right? You were high risk to miscarry. You did not miscarry. You are not high risk.
But I'm seeing a maternal fetal medicine doctor. I'm like, yeah, because you're still seeing them, but not because you have a risk anymore.
Because they can keep billing your insurance.
No,
it's so true.
And you've gotten to love, and you've gotten to know them, and that's lovely. But yeah.
I think that's another term. Thank you for bringing that up. High risk. I really feel like people need to just wipe that out. There are so many reasons that this term is high risk is thrown around, and it freaks people out. It really should just be abolished. It's not helpful to label any pregnancy high risk, because there are 1,000 reasons why it could be, quote, high risk. And some of them are, like you said, first trimester miscarriage related. Some of them are chromosomal abnormality related. Some of them are growth and development related. Some of them are pregnancy and birth related. You might be high risk because, you have a history. I had a patient once who had a history of a brain aneurysm. And she was not, because of, she had to have open head surgery, brain surgery. They were like, please don't ever push. If you get pregnant, you need to have a scheduled cesarean. And so she was, quote, high risk. Right. But she wasn't high risk for anything else. Right. Like they didn't want her to push. She knew she was going to have a cesarean, but otherwise that baby was healthy as healthy could be. It wasn't that the baby was going to be in any way damaged by the fact that, she had this crazy brain past, it's just like
crazy.
Well,
so
I have one. I have a favorite. Incompetent cervix.
Incompetent cervix. Well, that damn cervix and its incompetence. You really got to get a more qualified cervix.
We got to train those cervices better.
Exactly.
Just awful. Well, we know who came up with these terms, but
men.
Men.
Yes, of course. Absolutely. It's ridiculous.
Yes.
Yeah.
How about
incompetent?
It's an eager cervix. It
Eager.
It wants to help. It wants to help get the baby born.
It's a helpful cervix.
Oh my gosh.
I see a little face.
I had when I was the same baby, second baby, I was told I had an irritable uterus.
Oh gosh.
Irritable.
Yeah, it was an irritable uterus because I couldn't do much vigorous exercise, or I was having contractions and it was too early. But I just walked around. I thought that was the funniest thing. Like, really, my uterus is irritable. Would you just calm the heck down? Like, what is wrong with you? Would you need one? I mean, what do you need? You need
what about excited? You have an excited uterus. That sounds so much better than irritable.
Or your uterus is practicing.
Dynamic.
And she was born in 45 minutes. So, my uterus was doing its job. But the irritable part, I thought that was hilarious. And I don't know if that's really common where you guys are, but I didn't.
Oh yeah, no, that's definitely something that we hear. Yeah, you have an irritable uterus. Yep. Yeah, these words, they really, they just roll off the tongues of healthcare providers, you know, I mean, and
Uh-huh.
it's because that's what we were taught. I mean, when
Mhm.
you put someone on the monitor and they're having teeny tiny little contractions, we're told that's uterine irritability. I mean, that's
Oh,
the medical
right.
terminology. So,
Right.
so when you're
Uh,
taught that, you're going to tell someone you have an irritable uterus, right? But, you know, and so people, they're not thinking about how that comes off.
mhm.
I remember one time,
It's crabby.
so
It's a crabby uterus.
Crap.
we right,
That's a,
exactly.
that's a,
We
that's
have
another
to
illness,
monitor
and
the
all of
babies
it's
with
that's a
Yeah, that's
different illness
crabby
altogether.
uterus is different. So we have to monitor the baby in labor, in some labors, right, with the hockey puck external fetal monitors. And, you know, I just picked up from my orienter, the way that I was taught was, you know, when the baby, like when the monitor stopped tracing the baby's heart rate, you know, you'd go in, you'd be like, oh, I lost the baby. Let me just, you know, find the baby.
Jeez.
And I said this for years.
Oh my gosh.
Right. Again, I'm like 23, 24 years old.
Mm.
And then I had this dad once, and I had been a labor and delivery nurse for probably 4 years. Oh, I lost the baby. I'm just going to come in and find him. Thinking like, you know, just going to move the monitor. And he said to me, could you stop saying that? And I'll never forget it. Like it like is burning in my brain. I was like, say what? He goes, that we lost the baby because, you know, we lost a baby.
Oh,
And I just like, my heart broke.
wow.
I never, ever thought that that's how that would be taken. Again, this is before I had children, right?
Mhm.
I never said it again.
Mm.
You know, I
That's
have to
great
find
that
the
they
baby's
told you
hiding
that.
from the monitor. I have,
Yeah.
you know,
Hiding.
but it was very, you know, the baby's hiding from the monitor, or you know, the monitor slipped. I just have to move it around, or because
Uh-huh.
you know, you do want to reassure people when you come in and the heart rate isn't tracing. We also have to tell people stop looking at the monitor because it's
Right.
not perfect. But you know, they don't see the baby's heart rate, or maybe they see their heart rate and they think the baby's in distress and they freak out. They're on the call bell. The baby's not off the monitor. So you know, you're trying to oh, I just lost the baby. Oh, you know, the baby's just
Yeah.
hiding from me. You're trying to reassure them, but
Yeah.
you have to remember again, like that people are, you know, lay people are taking it differently than than the medical person is saying it.
Right.
You know, I'm trying to reassure them, oh, you know, I just lost the baby, not that the baby's in distress, and they're hearing I lost the baby. You know,
Yeah.
that's just
awful, yeah.
it's I'll never say it again. So,
But
all right, Jeanette, what's next?
A less serious one, as far as scary, I mean, but the idea that like, well, I wasn't allowed to, or well, I had to do this, or they wouldn't let me do that. And there's such a great statement of like, your care providers are not allowed to not allow you.
Right.
Right? You're not getting permission from adults. You're an adult. And as I always like to say, and make people repeat after me, I am a grown-up. Like, you are a grown-up. And if you having a child and you're in the process of labor, or you have a child and you're making decisions for yourself or that baby, I don't know what's going to make you think you're a grown-up other than having a child. Like, you're a grown-up now.
Right. That's
you're having
grown-up
another
thing.
human. So, you know, it's really about, no, they gave me information and I agreed to. Or I chose to let them do the following thing, or they suggested this and I asked them if they could do that for my baby, you know?
That's not how you feel when
I
you're in the
accepted
hospital.
their
I know,
You,
right?
you, they, for some reason, you have to wear this weird gown.
Mm-hmm.
You know, you're being told where to go, even though, you know, I was pretty well informed, but I was put in a position that I knew wasn't right, but I just did what I was told. And that's one reason why the second one was born at home. But, you know, it's, you just do it. You give over any autonomy that you have. And I beat myself up for a really long time for allowing things to happen. They weren't, and they weren't terrible things. None of it was terrible things by anybody's, you know, anybody would look at it and say, yeah, you had a good birth, you had a good experience. But there were things where I gave up my autonomy, and it's just set up for that. And so, yeah, it's like they told me to do this, so I did it. And I think that's a feeling that a lot of my clients have. Well, they wouldn't let me.
I couldn't do skin on skin
They told
because
me I
they
had
wouldn't
to give
let
formula.
me. They told me I had to give formula.
Right.
Yep.
Right. They told me I couldn't hold my baby in bed with me. You know, whatever it is.
Yeah. Kristen Pascucci from Birth Monopoly has great resources for this. The what you said, Jeanette, like they're not allowed to not allow you. Basically, like your rights as a birthing family in the hospital and whatnot. But I'm sorry to interrupt, Renee. You were saying?
No. I think I really didn't have anything to say. I was just commenting on what you were saying, is that it's just the whole situation that sets you up for feeling like you don't have a voice. It's the whole thing. You are just in there and you feel vulnerable, and it's not your setting. It's not, you're vulnerable, I guess. And so you're not going to say, well, don't do that, because you don't want to endanger your own life or your baby's life. And they know best, obviously, because there you are, you're in this weird environment. So it just sets up somebody telling you what to do, and you just doing it and not realizing that you do have a choice.
Right. You have choices. Yeah.
And we've talked so many times on this podcast before, Jeanette, I'm like a broken record, but taking childbirth class and hiring a doula and practicing using that autonomy throughout your pregnancy, asking questions, questioning things that seem routine, really, nothing can guarantee a perfect birth or the birth you want, or vaginal birth or a natural birth or whatever. Right. But I do find in my experience that people who have exercised that muscle of saying yes and no, right. And not being in the mindset of being allowed to, but being in the mindset of that I am a consumer of healthcare and I am choosing to give my healthcare dollars to this place and they are lucky to have me. I could bring my healthcare dollars to any other hospital in Massachusetts. I don't know about where you are, Renee, but where we are in Massachusetts, I mean, you can throw a rock in any direction and hit a hospital.
Pretty much.
Around here do not have, they do not have, an excuse to say there are places in this country where people have to drive hours to find an OBGYN.
Right.
So practice, exercise that muscle in pregnancy of saying yes and no, of accepting, or, and like Jeanette said, it's not that they allowed you, it's that they recommended, and right. you thought about it and you decided to accept or decline. I mean, it might be the same outcome, but it really matters how you view it. It will change the way people interact with you, for sure.
Well, and I think it changes things that when you go home too, because it changes how you feel about the choices that you made. If you feel that you had a choice, then you're going to view that experience differently. And you're going to possibly view your experience with your baby differently.
And your experience as a parent, you're going to feel like, oh, I am a parent because I made those decisions. Look how grown up I am as a parent. It sounds silly and infantile to say that way, I think, but it feels good.
No, but it's true. Sometimes I'm still actually amazed that I am a grown up and I have children that I'm responsible for. Like, I don't know. I know you guys are a little bit older than me, but do you still think sometimes like, wow, I'm the grown up here?
I think
my parents are the grandparents.
Yes.
Renee, you don't feel like you have grown children, right?
No.
It's like they were little yesterday.
I mean, my gosh, my oldest turned 30, in March, and I was just, no, this cannot be true.
Yeah.
And
all right, so it's not just me.
No. It really, and then I always say, you used to make that face when you were 2 years old. It looks just the same. Right? Don't they look just the same as when they were babies? And so that's what keeps them young.
Yep, for sure. So I'm going to take a moment in the middle of our show here to ask everybody who's listening to visit babiesincommon.com/show to view all our previous episodes and share them with your friends and family. And our show is available as a video recording on our website, as well as a podcast on our website, Spotify, and Apple Podcast. So be sure to click the subscribe button on whatever device you have so you can catch all future episodes.
And that's right, Jeanette, you wouldn't want to miss a single one. And we hope you take this opportunity to pause right now and hop on over to the Babies in Common Facebook page or Google listing, or even your podcast app, to write a positive review for us today and help us reach more families. And lastly, please visit our website or social media channels to learn more about groups, classes, and other services we offer, as well as plenty of tips and resources to help you rock your birth and thrive as a new parent. Okay, back to our show. What do you guys think about delayed cord clamping? This is a big thing people are taught to ask for, as they should. And there's lots of research to back up how important this practice is. But is that really the right way to describe what we're doing here?
And that affects our work, Renee, as a lactation consultant too, because people are talking about, did their baby get enough iron? Right. What are they saying in the Washington area for delayed cord clamping, or is there another word you've heard?
No, delayed cord clamping is, I can't really say it. Cord clamping. There you go. Yeah, that's the way people talk about it. And, you know, I don't hear a lot about it from my end because people are I don't usually see people immediately after birth.
Right.
So it's not something that they're really discussing or asking me about. But you teach classes for childbirth classes and stuff, so I'm sure that's a discussion in your classes.
Yeah, I loved it when Melissa came. Did you come up with that expression, or you heard it somewhere? Appropriately timed cord clamping.
Oh, I like that.
Yeah.
No, I didn't come up with it, but I've tried to retrain my brain to say it.
Renee says not rushed.
Because when you say delayed, right. When you say delayed, it makes it sound like that the default, the best, the most natural is to clamp immediately. Right. And that's opposite. The best, most natural, most biologically normal thing to do is to let the baby get that, what's called, and here's a medical term that actually I like, the placental transfusion.
Yeah,
that's
like
actually the medical term for what is happening in the 30 seconds to 5 minutes after the baby is born. The placenta is actually pulsing blood into the baby. Here's another thing, cord blood. It's not cord blood. It's baby's blood that's trapped in the placenta.
Yes.
And we need to wait for the placental transfusion to occur in order for the baby to get all of their complete blood volume. When you describe it like that to people, and this is something that, you know, if any nurses are out there, I would hear in report, you know, nurses thinking that they're doing the right thing, like asking the parent, you know, with their little checkbook, would you like skin to skin? Okay, check.
Yeah.
Would you like delayed cord clamping? Check. It makes it sound like those are things that, like, the opposite or like the alternative is just as relevant.
Like extra.
It's like, that's not how you approach it. Right. Yeah. Like, and what would you like would you like the fried calamari?
Yes.
Okay, check.
Yes.
The Caesar salad upgrade? No, it's like, that's not what we're, like.
Would you like normal?
You always have to.
Okay.
Would you like normal,
Exactly,
right? I'd like everything we should change that. We should change that, like on the birth plans, quote unquote. You know, I want everything normal. As much normal as we can.
Would you like us to take the baby? Normal. Would you like us to take the baby away from you and as soon as possible and make sure that he's really cold and uncomfortable? Exactly. And then put her on a scale
instead of rooming in and skin to skin. Yeah. That's exactly right. Yes. We should say it like that. Would you prefer the biological norm or separation of mother and baby? Right? Like, would you prefer the biological norm or stopping of the placental transfusion? I mean, that's really what we should be saying.
Yes, I would love that. I mean, I feel that way about our food labels too. And I feel that way about breastfeeding. Like, breast milk is the gold standard. Breast milk is best. No, breast milk is normal. Right. You know, let's not say that we have organic produce. Let's say this is produce with poisons on it. So, you know, let's change. I mean, again, see, I'm weird about words, you guys.
No, it's good.
It really,
you're a West Coaster. No, okay.
It really bugs me. No, I don't know. I think if I, in another life, I may have studied linguistics, because I just think it's really important. Like, why do we have all these things, that a listing of things that have bad things that have not been done to this particular item in the store? So it's the same kind of thing. Like, why don't we just say, okay, this is normal. When your baby is born, they're going to go right on your chest, and, you know, we'll cut the cord in a minute, and then we'll do some other stuff, you know, when you're ready, when the baby's ready.
Totally. I actually I would get in reports sometimes the patient doesn't want skin to skin because they were asked, do you want skin to skin? And sometimes they would say no. And it always infuriated me, because that's not how you educate people. No. You don't say, do you want
you can
this?
say, here's your baby, here he comes, right? Look,
or you can say, just like you said, Renee, because sometimes people have this idea that we are going to hand them, because people have, if they especially didn't take class, these horrific Hollywood ideas of what birth is like. They think
Yes,
it's
that's
gory,
true.
right? I'm like, birth might be messy, but it's not gory, right?
Mhm.
And so they're expecting that I'm going to like hand them this blood-soaked baby.
Right.
I mean, this
Right.
is what people think in their mind. So if you say, you know, do you want me to put the baby on you immediately upon birth? Some of these younger patients especially are thinking, no, I want you to clean them first. And so they're just like, oh, okay, great. We'll take them to the warmer. No, if what you say, Renee, is, you know, when the baby's born, we will lay a towel on your belly. We'll place the baby on the towel. We'll dry off the wetness so that they're not cold, and then immediately place them skin to skin with you with a nice warm blanket over you so you guys can cuddle.
I love
and
that.
that's best for baby, right? That's best for baby because it helps regulate their blood pressure and their temperature and their blood sugar, and helps with bonding, and can even help them breastfeed earlier and longer.
Yeah.
Is that something that you like? Do you have any questions about that? I have never had even a 16-year-old patient tell me after I explain it like that they don't want it.
No
and I
way.
understand there are some people that have trauma histories and they might have an issue with their chest. When you explain exactly what this is and why it's important, I have not in 14 years had somebody say to me, no, but I've had plenty of people say, I don't want a blood-soaked baby. I mean, when you say, I'm going to, you know.
Yeah.
I could
Renee,
also see that maybe it doesn't have anything to do with how the baby's going to be. Who knows how they're going to feel after giving birth? You know, they may not want this screaming baby laying on them. I mean, they might feel kind of weird, you know, and they don't know how they're going to feel. So to ask them to figure out this checklist when they're in the middle of labor or something, I mean, you just, I don't care, just go away, leave me alone, let me have this baby, you know. I felt really weird. I couldn't talk to anybody.
Totally.
Yeah. And skin to skin too is something that we want people to do repetitively, but it's become this thing where, like, well, I did that right after the birth, but I don't have to do it again, right?
I did it 2 times today. You know, it's like putting baby on their tummy. It's all these things, like, 7 minutes of skin to skin. Check. Did that.
I always joke that we spend the rest of our life trying to get naked with somebody else. And your baby has been naked inside your body for a long time, and now they want to be naked on top of your body for a really long time.
Yeah, forever, basically.
Oh, I love you, Jeanette. I really do. Oh, that's so true.
And maybe
it's almost like
let them be skin to skin longer, then maybe we wouldn't be trying to get naked with everybody else.
That's true.
There is a research study in there somewhere. A nice longitudinal study. All right, so let's do 1 or 2 more and then we'll wrap up. So the concept of a quote unquote trial of labor after cesarean or TOLAC.
I hate that term so much.
Like, we're going to let you try to labor to avoid a C-section because you had a C-section with your first one, right? And we're going to let you do a TOLAC. And people automatically, like, you're labeled as, the TOLAC, you know? I've actually heard moms say it to me, like, oh, well, I'm a TOLAC. And I'm like, oh, what do you, you're going to
I've had to ask what that is. What is a TOLAC? Yeah, and now I know. But
that makes me think, too, about people who go, oh, well, I was a C-section. My baby was a C-section. My baby was a home birth. And I'm like, no, they were born by a cesarean or they were born at home. They're not a C-section. And it's so minor, and I think people roll their eyes when I try to go, but it's so interesting, just the nuances of what that does to our brain. So, Melissa, trial of labor
I don't like
after
the word
cesarean. How do you see that present
itself?
Makes
it sound like you're on trial for something. Oh, it's absolutely like this person's going to try, but they're probably going to fail. And it's something that, like you said, they're even a different color on the board because they're a TOLAC. And also the word TOLAC just, first of all, starts with toe, which I am not a foot person. So that is just weird to me. And then LAC is actually the medical shortening of laceration. So it's just such a terrible acronym to me.
But the word
like
LAC.
This whole, she's a TOLAC, she's a trial of labor.
But the word LAC, LACK, is a negative word too. right?
Yeah, that's
Lactating.
true.
So if you hear it as
That's true.
amatola,
Trial labor cesarean.
It
Wow.
just seems like
I hate it. I say VBAC. I say VBAC because I'm going to like you're a vaginal birth after cesarean. Like we're just gonna, what are we shooting
We're
for?
gonna
That's what we're
assume.
shooting for.
Yeah.
We're gonna assume that's what's gonna happen, that you are gonna have a vaginal birth after
Right.
cesarean. I'm not like repeat cesarean in waiting, trial of labor.
Right. Right.
Like, that just sounds-
Yeah. Renee, what were you going to say?
Well, just if somebody, I would think that if I felt like this was a trial, that I would just be feeling like everybody is watching me, everybody's expecting, like you said, that any minute now the C-section is going to happen, and am I doing it right? Right? Like it has something to do with me, and maybe I'm not breathing right, maybe I'm not in the right position, maybe all these things.
And then people say,
This whole
I
thing
failed.
about trying
I
too.
failed. Yeah.
Yes. The whole concept of trying, like, here's a question for you guys as IBCLCs. I hear a lot of expectant families when I say, you know, how are you planning to feed your baby? That's one thing actually that
I'm going to try to
instead of
nurse.
saying, are you going to do breast or bottle? Right. They say, I'm going to try to nurse. What's your response to that when people say, I'm going to try to nurse?
Yeah. Well, you know, they're usually coming, if they're talking to me, it's because they want to breastfeed, you know.
Right.
And so, you know, because I do prenatal visits with folks, and, you know, I will tell them, I'm assuming that this is important to you. Otherwise, you would not be here right now. And so breastfeeding is important, and that's what we're going for. So I think, you know, the trying to nurse, that happened with me and my ex-husband. When people would say, how are you going to feed your baby? I'd say, I'm going to breastfeed. And he'd say, well, we're going to try. And
oh man.
Oh yeah.
Man.
We had some conversations, because I'm like, no, no, that's not, I am going to breastfeed, you know. And so, I mean, I can't change how people are feeling about it, because there's so much out there, as you know, on social media about all the struggles that people have. And so people don't want to put themselves in a situation that they're going to fail. So they say they're going to try.
I have been saying for years in prenatal classes that, you know, people say, well, I'm going to try and go natural. I'm going to try and go unmedicated. I'm going to try and have a home birth, whatever. And I'm going to try and breastfeed. Nobody starts out any other sentence like that when we tell a family or friend that we're planning on doing something. You don't say, and we have the Boston Marathon here, right? So I use it all year round. You don't have a friend who ran the marathon and was saying up until the marathon, I'm going to try and run the marathon.
Right.
They're like, I am running the Boston Marathon on April 19th. That's what they're going to say. You don't have people who start college and go, I'm going to try and graduate college. We assume it's going to happen. I'm going to go to nursing school. I'm going to go to plumbing school, whatever it is. Like, I'm going to do this. I'm going to go to the store. We don't go, I'm going to try to go to the store. I mean, maybe you might say that because you're going to see whether you're lazy that day as an adult who can be lazy, who can admit they're lazy because they don't feel like going to the store. So that's a bad example. But right, like things we want to do, when we say we want to do them, we don't say we are trying, and our family members and friends don't say, well, I don't know if you're going to succeed at doing that. I tried to do that myself and that just did not work. Just run a 5K. A marathon's too hard.
Exactly.
You know?
No, yeah, it's so true.
I try to turn things around just by talking to them about the why, because obviously you're interested in breastfeeding, you want to breastfeed, you're planning to breastfeed, that's why you're here. What are the reasons that are so important for you to do this, so that they can have something that they sort of hang on to? Maybe it's allergies in their family, maybe it's just because, well, that's just the normal thing to do, the biologically normal thing to do, or you know, whatever it is, and then just kind of go with that, you know. Because, and then I think it's also important to talk, I know this is different than birth, because either you have a vaginal
not a virginal.
Not a vaginal. That doesn't happen too often. But whether you have a vaginal birth or a C-section, it's either one or the other, right? So with breastfeeding, there are lots and lots of ways to breastfeed. So I think when people are saying, well, I'm not sure if it's going to work, I'm going to try, I had a hard time last time, blah, 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 then I think that helps us talk to them about how many, you know, there are lots of ways to breastfeed. It is not an all or nothing.
True.
situation.
The other thing about that does work for breastfeeding and works for birth is that you're also still talking about two people.
Exactly.
And even if your first baby, your second baby did not come out vaginally, doesn't mean that this baby can't. And even if you didn't reach your breastfeeding or lactation or feeding goals with your second baby, doesn't mean your third baby won't come out going, I know what I'm doing.
Yeah.
with perfect anatomy, you know, like, so
Exactly.
it's not all just about what the adult is doing in the situation.
Mm-hmm.
And I remember, I don't know if you remember this, when we interviewed Justine Leach, I think it was episode 14.
She's so good at remembering.
I'm a
She
big
knows all
How do
the
you
numbers.
know that? How do you know that?
Because I actually assigned these episodes to my childbirth ed students.
Right, that's right.
Oh.
That's why.
So you start to memorize them.
But Justine Leach I remember her describing, because she's a childbirth educator, and she specializes in trauma, basically childbirth classes for people with a history of trauma, and teaching providers about trauma-informed care. Really very interesting. I highly recommend checking that episode out and learning more about her. But she did talk about, I remember her saying, like, you know, when I have a client who, like, for example, really strongly desires breastfeeding or really strongly desires not getting an epidural, and then they don't breastfeed or they do get an epidural, you know, saying them, well, you've shown like you make really good decisions, and this was something that was really important to you. And so if breastfeeding didn't work out in the way you envisioned, it must have been for a really good reason, you know, or like if you ended up getting an epidural, it must have been that was a really hard choice. I mean, you make really good decisions. You were really working hard to do that. And so, you know, there must have been a really good reason that you got an epidural, because it was so important to you not to, right? Instead of phrasing it like you failed at a natural birth, you failed at
really
breastfeeding.
Hard.
If breastfeeding is that important to you, and it didn't work out because of whatever reason, you have serious hormonal imbalance, and you know, with everything you tried didn't make enough milk, or the baby, everything you tried didn't, there must have been a really good reason why it didn't work out in the traditional way, you know? So I think that is so important to like validate that. I know people are nervous. I feel like people say things like, I'm going to try to breastfeed, or I'm going to try to have a medicated birth, because they want to have an out.
Yes.
You know,
absolutely.
like if it doesn't work out, like I was just
I wasn't that invested.
I didn't get my hopes up.
Yeah.
Right. Exactly. Like, you know, because they don't want someone to say, well, I told you so.
But that's also because we have such a weird culture where we actually hear people say that shit to people. You know?
I know,
like,
it's
just not nice.
It's
like,
super
be
true.
nice to people.
Yeah. My own husband. Well, we're going to try. Well, who's this we?
It's true.
Like that. This is... I'm making this decision.
Who's this we? You over there with your useless nipples.
I hope he never hears this.
All right. Well,
I'm sure this is not on his podcast rotation.
Right. All right. Anything else? One last one that you wanted to mention?
I think it's good.
We covered so many.
No, I think we really covered so many. But I would love to hear from our listeners if they have a phrase that maybe they've heard or they were told while pregnant or breastfeeding that they feel like needs to be changed. Definitely send us an email, info@babiesincommon.com, or post it on Facebook under this episode. Will be episode number 40. Woo-hoo. I can't believe we've done 40 episodes, Jeanette.
Yes. Well, another riveting discussion. Thank you so much, Renee, for coming on for 2 episodes. That's amazing.
It was great. I learned some things.
I did too. I'm going to stop saying, what was that thing I said last episode? I'm going to stop saying, working so hard. Right.
Yeah.
Yes.
Yeah, there you go.
Yes.
All right. So we hope we've inspired some change, and we hope everybody's enjoyed the show, and they'll tune in again. And remember that Babies in Common is a community for you. After all, we all have babies in common.
Babies in common.
There we go. All right. Have a good night, everybody.
Happy Thanksgiving, everybody.